has bipolar disease. He has bipolar disease, COPD, hyperlipidemia. His medications actually are pretty minimal. He's on insulin, ACE inhibitor, ezetimibe for cholesterol, vitamin D, which we've started since we started the Hep C workup. He was not immune to Hep A as of when his labs were drawn, but he got a shot yesterday. And he does have immunity to Hep B, which may be from a past infection. We're really not quite sure about that. His vitals, he's 6'3", 273 pounds, so his BMI is elevated at 36. His blood pressure, actually, the last one was 140/84, so that's not ideal, but anyway, so if you keep scrolling on down the labs, his white cell count, CBC was actually pretty normal. His kidney function is also normal. Protime was not elevated. Liver enzymes are not elevated. That glucose of 142 is probably pretty typical for him. Keep going. Let's see. And there you can see some of the calculations in the other labs. His vitamin D, as I say, was low. We have started him on the replacement. But he's genotype 2B with the viral load that you can see there. His HA1C is 7.8, which obviously is not ideal, but we're trying to work on that. So the question is, how do we treat this gentleman when he's hard to reach, hard to get in? He lives 20 miles from a hospital, and I've talked to him about getting imaging on his liver, and he just says he doesn't have the gas money to get there. He would have to hire somebody. He doesn't have a car. So I guess the questions in my mind are, can we treat him with the generic Epclusa that his insurance will cover? And then what is the kind of minimum that we can do here to keep his liver as healthy as we can get it?
Awesome. Thank you so much, Dr. Rexroad, as always, for an excellent case presentation. Before we jump into the case recommendations, did anyone have any clarifying questions for Dr. Rexroad? Feel free to unmute or chat in. All right, and any recommendations or feedback to her questions?
Dr. Rexroad, this is Jennifer. You might have said this, but I forgot. Was he diagnosed just on routine screening? It's such an interesting case.
I believe the NP kind of got the history from him that, yeah, there might have been some sort of hepatitis, and so she started digging and found it.
Gotcha.
And Dr. Gilfus, I think that number ending in 0724 is you. If you're able to unmute, that would be wonderful. It's *6. I'm not sure if that helps at all, but no worries.
Did he get a, I'm sorry if he went over this.
Am I unmuted?
Oh, there you are. There's Dr.
Yes, Dr. Gilfus, we can hear you
okay.
now.
Yeah, sorry, I'm midway between Washington, PA, and Moundsville, heading to a away clinic. The minimum you can do for a patient like this, and by the way, I couldn't see the labs, so nor did I hear an F score while I was driving. I apologize. Do we concern that he has advanced?
His fibrosis score was 0.48. And he has normal normal enzymes, normal alk phos, normal total billy, I think.
Dr. Gilfus, you may be going in and out there. Were you able to hear that okay? Oh, looks like his call dropped. No worries at all. He'll probably hop on here again shortly. Did anyone have any other recommendations or feedback from the hub? Rachel, I know you're on there as well. Angie or Dr. Lee, if you all had some feedback as well, that would be wonderful.
I'll just jump in and say from an ability to get the medication from the pharmacies, probably with his Medicare, a little bit harder for him to get Epclusa from maybe a local place, but a specialty pharmacy should be able to deliver it. And I know we here at Allied and Med Center in Charleston as specialty pharmacies will utilize UPS and couriers. So as far as getting it to him, I think, so long as he has a phone number and the pharmacy is able to get in touch with him, could do that. But from a lab standpoint, I don't know, the follow-up and getting the SVRs and things like that, how to accommodate that sort of process.
Yeah, it's just transportation's a big issue for a lot of our patients, and we're not alone in that around the state. So it's just a matter of, there are people out there we'd like to treat, but some of these hoops we have to jump through. I mean, they're not hoops to jump through, but I mean, some of the things we have to do for follow-up do make it harder sometimes.
Petra, this is John. I'm back on. Did questions get answered yet?
Yes, Rachel was able to answer some questions. Dr. Rexroad had the F score for you as well. Did you want those repeated?
If Rachel took care of it, that's okay. Sorry.
No worries at all.
I would be interested, John, if you were going to say something about imaging or anything like that. I mean, should we pursue that? He's gone again.
Dr. Gilfus, you are still muted.
I didn't hear the question. Sorry, there's no transmission on my end.
She was just wondering if she should pursue any imaging.
Oh gosh, get it out.
Hey, this is Jean. Can I chime in?
Absolutely, yes.
Hey, this is Jane. I'm in hepatology. I just wanted to chime in a little bit on imaging. From a hepatology standpoint, if he doesn't have advanced liver disease, then that's lovely. But what I worry about over time is, this guy sort of falls off the face of the earth and doesn't follow up for his appointments. Getting him the medications, getting him cured from hep C is great, but he also has, diabetes is not that well controlled. So I'm worried about some underlying fatty liver disease as well. So I don't know if, I don't want him to fall away and then end up with liver cancer 5 years down the road just because maybe he has, F3 scar tissue, he's not cirrhotic, but over time it can progress. So I think that it would be a benefit to get imaging on him. I don't know if it's required before treatment, but I think it needs done to follow up with him.
Okay. I think this gives me a little more, something heavier to nudge him with, maybe, that you guys are saying this. So.
Thank you so much. And thank you, Jean, for that comment as well. Dr. Rexroad, did you have any other outstanding questions that you had for the hub members? I'm more than happy to take note of them and maybe relay the message later on and get that back to you after the fact as well. But did you have any other questions before we move to the other cases?
I don't think so. I think this is good. Thank you.
Awesome. Thank you so much, Dr. Rexroad, and thank you all so much. All right, Dr. Fournier, I'm going to share my screen and pull up your cases. I know you have two here. Did you have a preference which one we start with?
I'll start with the one you have up there with the 38-year-old male. That would be great. So
sounds good.
Yeah, I have a 38-year-old male patient, former IV drug user, hasn't used since 2010. He's been on Suboxone, very well since that time. He had been probably right after he got off drugs. He had been my patient for a number of years, and then he just fell away from, and at the time, again, that was before all these meds were available. We knew he had hep C, he had been tested, and I would periodically follow up with him for liver levels, but at the time it was just interferon therapy and he wasn't interested. Again, he fell away for a number of years. And then he unfortunately had a major car accident just almost a year ago, and a traumatic brain injury, and ended up like 3 or 4 weeks down at Ruby for this traumatic brain injury and a coma. And so when he came back, then he needed health care again, and his family brought him back to me. So we decided we should look into this hep C treatment now. So he is genotype 1A, viral load 837,000. His AST, ALT has run typically about 38 or 50 respectively, but he was in the ER some weeks back for some alcohol intoxication, and his levels were up high at that particular visit, whereas ALT went to 148 and ALT was 148, AST 110. He did have a CT of the abdomen because, so unfortunately, this traumatic brain injury has left him with some frontal lobe issues, impulse control problems. So he has a good family support, thankfully. So he's been compliant with coming to appointments, but unfortunately he's had gotten a couple of fights, ended up in the ER, alcohol and stuff. So they had done a CT of the abdomen in August of 2021, and it made mention unremarkable liver. Because his APRI scores and stuff were low, and we'd had that CT, I didn't do any additional imaging. I think he is lower risk that he's not overweight. He would, other than this traumatic brain injury, was a healthy young man. I had he's hep A and B vaccinated. When I had submitted this to Medicaid, so actually initially in the spring, it was before he was on a lot of his current meds, and I was asking for Epclusa, but I'm thinking maybe Mavorite would be better because now he's on like Nudexa, he's on Depakote, and they keep switching his meds a bit to try to level out for mood stabilizing. So I have a feeling he might be on and off different anti-seizure meds more for mood stabilizing. So maybe Epclusa isn't the better option, but I'll, take recommendations on that.
Thank you so much, Dr. Fournier. Great case presentation. Any clarifying questions for Dr. Fournier?
I'm completely unfamiliar with the Nudexa.
It's for pseudobulbar. It's dextromethorphan with quinidine combination. He gets it through psychiatry, neuropsych.
And any recommendations or feedback for Dr. Fournier's case, feel free to unmute or chat in. And this is a safe space, so everyone is welcome to unmute.
Well, from a drug interaction standpoint, I'll jump in quickly here. I guess the concern would be just from the mood stabilization and using the different anticonvulsants. So the biggest offenders are going to be things like Tegretol and Trileptal, as well as phenobarb and phenytoin. Those four are the big four. It doesn't matter what DAA, they're all contraindicated because all four of those agents are enzyme inducers. So they're going to cause subtherapeutic levels of all the DAAs, so risk in therapy with those. The concern with the Nudexa is that quinidine component of it, and it's going to again be an issue with. I think he has Medicaid, so all three of their options then with the Zepatier, Epclusa generic, and the Mavorite. All three of those are going to be, they have a slight inhibitory effect on P glycoprotein. So there is a chance of increasing the quinidine. So putting at risk the scary things we hear about with quinidine anyways, with having a narrow therapeutic index and risk for arrhythmias, torsades and things like that. So they're not contraindicated with the new DEXA, but it is something to be aware of, where I'd probably recommend really close monitoring. I don't know if he's had an ECG or anything recently where you would have any idea what his QT interval is to know what his real risk of torsades is on this drug. Sounds like if he's being switched, it might not be stable yet, to really know what his risk of torsades would be. But that would be my main concern, is if they are switching, like the Depakote is fine right now, but if they're going to try those 4 ones, that would not be great while he's on hep C therapy, for the risk of failure, and then really the close monitoring with the new DEXA, because we just don't have a whole lot of information that's going to give us a good idea of how to manage that.
So what, I mean, and he can be followed, closely. Would there be a different drug that, like something that's off label that I need to try to not off label, but not on formulary, that I should try to prior auth, or just go with more like the Mavorite and follow him closely? Or do I ask psychiatry, is this not a good time to treat, or can we hold that?
Well, honestly, even the only other thing that would be really off label that I can think of that is an option is going to be the Harvoni. And it's still going to have that same concern.
Okay.
Thank you, Rachel. And Jean, I noticed you had unmuted as well. Did you want to add to that?
No, sorry.
No worries. No worries. Thank you. Dr. Gilfus, I saw you unmuted there as well.
Yeah, I don't know if you can hear me. Hopefully so. I, in situations like this, I've had a direct conversation with the mental health provider and communicate the concerns of drug interaction. And, you're only talking a short time period of 8 weeks. And if you choose the Mavorite, and very often the mental health provider is comfortable either putting those on hold, or if they're not, then perhaps that's a realization that it's not the appropriate time to treat the hepatitis. So I would just have that conversation directly with the mental health provider, let them know the concerns, and obviously if they propose an alternative mood stabilizer, keep Rachel on speed dial.
Okay, yeah. I appreciate that feedback. I will certainly do that.
Awesome. Thank you all so much. If you're ready, Dr. Fournier, I'll pull up your second case.
Thank you.
Alrighty, I'll turn things over to you again.
Thanks. So I appreciate we added this one on, because this one, there was maybe a little more urgency. She is followed by one of the nurse practitioners in the practice who referred her over to me, a 38-year-old female, prior IV drug user. She found out about 10 years ago while she was incarcerated that she had hepatitis C. Her IV drug use had been those few years prior to that. She has been since clean of IV drugs for more than 10 years. She does take a quarter of a strip of Suboxone that she gets from a friend a day. I asked why she doesn't go in through appropriate provider for that, and she says that she works, she's married, she has kids, and she just doesn't have time to do that, and this works for her. So she's known she's had the hepatitis C, she said, and while she was incarcerated, she did get her Hep A and B vaccination. At the time, they only had interferon to offer. She chose not to do it and said she just really didn't seek treatment for years, just because she didn't think it was bothering her. And again, she said she was busy, but she had been referred to hematology for some pancytopenia issues, particularly low platelets. Hematology has done a big workup, and basically they feel that it is the hep C that is her underlying issue. And they told her they think if she would treat her hep C, that would fix her issues there. So that's why she came to me. Her current meds are ProAir, Omeprazole PRN, Wellbutrin XL, that she's been on for a long time for a mild depression, levothyroxine, sertraline, and vitamin D. She is normal weight. She had normal vitals. In September, her white blood count was 1.8, hemoglobin 11.7, platelets 54,000. And that it seems like the platelets have been pretty much running in the 50-some thousand range and keeping that white count 1.8 to 2. So she does pretty much monthly blood work through hematology. I did just do a sonogram on her, and there was, it just said there, prior cholecystectomy, no evidence of cirrhosis, somewhat dilated portal vein. That was what the report came out. Her ALT was 268, AST also was 268. Her APRI score 13.1, her Child-Pugh score of 6, and a MELD score 7.4. Her viral load was 1.5 million. Her genotype is 3. So I was hoping I wouldn't to get her treated sooner than later to try to help out these blood dyscrasias that she is having. Unless you think I need to do any other FibroScan or something ahead of time, I'd like to maybe get her on the Mavorite, because it'd be like 8 weeks, relatively quick treatment.
Thank you so much, Dr. Fournier. Any clarifying questions from the group?
Yeah, me.
And any?
Sorry, am I there?
Yes, Jane, yes, we can hear you. Feel free to chime in.
Hey, this is Jane with hepatology. I just have a question. You said the CT scan does not show concerns for cirrhosis, but our APRI is 13. Is that what you said?
Correct. So because the APRI was high, I ordered a sonogram. I did a sonogram, and the report said no evidence of cirrhosis.
I'd be very concerned that that's an accurate report because of the platelets, because of the white cell count, because of that APRI, and because of the genotype 3. Genotype 3 has a tendency to have worse liver effects over the long term. I'm really concerned this lady has cirrhosis. I mean, treating her would be ideal, obviously,
Yes.
but you know, she's going to need some long-term follow-up, I think.
Thank you so much, Jane. Any other feedback, Dr. Gilfus?
Is there any way you could get an elastography? I 100% agree with Jean. This lady has cirrhosis.
Yeah, I know it's
even the portal vein, dilated. I don't know how dilated the portal vein was, but
Right, that comment also to me, I agree. So I can probably get that done somewhere. I don't know if we have it at our local, but I could probably get it referred. But would it be okay to get her started on treatment first, since she's going to need the treatment?
Just a couple caveats. Remember, this is the type of patient where there can be a danger. Is there any concomitant hepatitis B co-infection? I couldn't hear that part. My apologies. Any
Sorry, no.
B?
She is immune. She shows immunity to hep B and no history of hep B infection.
Okay, so core antibody negative. Yeah,
Correct.
And remember, these are in genotype 3 patients with baseline cirrhosis. They are the ones that baseline NS5A polymorphism testing is recommended, especially if you're going to use Epclusa.
Okay.
I would just monitor her very closely. What is her ethnicity, out of curiosity? She's
Caucasian. Caucasian.
The rationale being sometimes there's differences in white blood cell counts among different ethnicities, and just making sure she has the classic CBC of cirrhosis. Yeah, you could get her treated. Obviously, your genotype 3 options are, the pangenotypic agents. So it's going to be Mavorite or Epclusa. Just with that caveat, since she's cirrhotic, you would want to try to do that testing ahead of time, looking for the polymorphisms. And it's a hard test to order. If you sort of send us a message afterwards, Kaylee or myself can direct you on how to.
Okay. Thank you. Okay. I will do that.
Dr. Gilfus. And Dr. Fournier, you're more than welcome to email me as well if you want anything relayed over to the hub team. Thank you.
Okay, I appreciate that.
Were there any other feedback or recommendations for Dr. Fournier's second case?
Mitra, no direct for that case. I didn't know if we had 2 seconds to announce some Medicaid changes, literally 2 seconds. I know
Absolutely.
we're Gene's time, and I know we have Rational Drug on the call. Just note, I guess West Virginia Medicaid made a few important changes lately. Number one, they dropped the 1 treatment per lifetime limit, as long as there's a good justification as to why treatment would be indicated, number one. And number two, excitingly, oops, sorry,
Dr. Gilfus, we heard the first
back again. So the second part of that was no longer are they requiring a second viral load at 6 months prior to approving treatment. So that's wonderful news, allows us to treat our patients more quickly. Those are a few obstacles to therapy we've been facing. So both of those are going to go away. I commend Medicaid for their progressive thinking.
Thank you so much for sharing that. That's great news and really important to share with the group. So, and Rachel, I believe you had sent me some information on that as well. I was able to distribute it to our listserv. So if you have any other information on that you'd like me to send out, I'm more than happy to. All right, and Dr. Fournier, any other questions you had about your case before we move to the didactic?
I don't think so. I appreciate it.
Absolutely. Well, thank you to both Dr. Fournier and Dr. Rexford for the cases. And Dr. Fournier, I know that was one of your first case presentations. So I just wanted to give you a shout out. You did awesome. So thank you. All right, Jean, I'll pull up your didactic for you and turn things over to you anytime you're ready. Just let me know when you'd like me to advance the screen. I believe you are still muted right now.
How's that? Is that better?
That's perfect. Thank you.
I guess it's better if you can hear me. So my name is Jean Kernel. I'm an advanced practice nurse. I do hepatology. I've done this for about 16 years. I came from a transplant center down south, just to give you a little bit of background of where I'm coming from, I guess. Cirrhosis is sort of my preferred group of patients, I guess. I just think they're fascinating, you know, and cirrhosis never gets old because it has so many problems that can, you know, occur, I guess. Okay, you can flip it. So we're going to talk today about decompensated versus compensated liver cirrhosis. I get a lot of questions about what this means exactly, because you would think that some of the things makes them decompensated regardless, but not necessarily. You can flip. So on this screen, I just wanted to throw up there a couple of, you know, prompters for all the things that can cause liver disease, liver failure, and ultimately cirrhosis. Cholestatic liver injuries, as opposed to hepatocellular, sometimes they act a little bit differently. The course to getting to cirrhosis can sometimes be a little bit different. The tissue certainly looks different if you put it under a microscope, but regardless, the end result is end-stage liver failure, you know, a pronounced amount of scar tissue, and whether or not they're decompensated or not. You can go ahead and turn. So with this slide, you know, I just wanted to talk a little bit about compensated because, you know, you can be compensated cirrhotic, meaning not having any complications per se, and still have all of these things. So you can still be chronically nauseated. You can have horrible appetite. You can be malnourished. You can have a huge spleen. You can have all of these things wrong and still be considered compensated. You can have platelets that are in the 30s. You can have a white blood cell count that's 1.4. Doesn't really make any difference. As long as you're stable on or off of medications, you're considered compensated. Okay, go ahead, next page. So for decompensated, it gets a little muddier, I think, because you can sort of float back and forth between decompensated and compensated. Some people can present to the hospital, they're floridly jaundiced, they're decompensated. That resolves, they're compensated. Now they develop swelling and now they're decompensated again. So it's sort of a fluid, approach to how you treat these people. Some of the more prevalent questions, I guess, that I get is about, sodium levels and INR levels and those kinds of things. You can have a sodium level of 122 and be totally compensated. That's not emergent. That's probably that person's normal, and we don't want to try to fix it because it causes more confusion sometimes. You can have a bilirubin that's 7, but it's been chronically 7 and they're compensated. So, it's really dependent upon their independent disease process. You can have somebody who's fairly stable cirrhotic, for example, put them on hepatitis C treatment, then they become jaundiced, now they're decompensated. So hep C treatments are always great. I think everybody should be treated, obviously it's going to prevent additional damage, but whenever they're already cirrhotic, it tends to be a little bit tricky because some of these people can have, bad outcomes and it can go quickly to bad. So I worry about them. People with decompensated disease include people that have thrombosis. Portal vein thromboses are pretty stable for the most part. They don't cause a lot of, other problems. We don't really put them on anticoagulation, but they can have other problems, especially if that thing, proceeds into like the superior mesenteric, or if it goes, your INR starts to climb or whatever, these people can really have a fluid approach to decompensated versus compensated disease. Go ahead. I thought this was an interesting slide because this slide actually is a huge reference for me. You can have compensated disease and the risk of going to decompensated within a year's time is about 5 to 7%. So it's really pretty low for developing decompensated disease. Once you have decompensation, then over the course of the next years of however long you have this, you have an increased risk of developing complications. So, within 5% or so of developing one issue, you have these other risks of developing these other things. The numbers on the bottom, those percentages underneath the topics, that's your mortality rates. So if you're going to get a decompensation, not that you get to choose, but if you're going to develop a decompensated state, the best one to have is fluid overload. That's the worst one that patients complain about, but that's the best one in order to continue living. Hepatocellular carcinoma, you would think has the worst outcome, but it doesn't. As you can see, maricel hemorrhage and encephalopathy is worse. So it's always boggles my brain that, somebody that has confusion has a higher mortality rate than somebody with liver cancer. But it's really true because whenever they're encephalopathic, so many other things become a problem that they have a shorter course of life. Obviously, maricel hemorrhage, if you burst of varices and you're bleeding to death, that's why that number is so high. And each one of these individual complications has their own risk for developmental process. So for example, maricel hemorrhage, you have a couple of them, you get banded, you have no bleeding episodes, you're much more better off, obviously, than somebody who's had one bleeding episode. We went in, we banded them. If they have additional episodes of bleeding, they can have increased rates for mortality by 10, 15, and then upwards of 45% on each time that they bleed. So we really try to prevent that from occurring. Go ahead and go to the next one. So for encephalopathy, you know, the biggest thing is I try to tell people that this is sort of on a sliding scale. You know, people can have sort of mild symptoms or a little bit off. They don't really make jokes like they used to. They don't really interact appropriately like they used to, or respond to facial expressions anymore, but they're not confused per se. You know, they're doing okay. They're still working. They might say some things that are funny, or maybe have a hard time making change quickly from a dollar bill or whatever, but they do fairly well. This continuum or sliding scale goes all the way to a severe, which is like in a coma. So I usually try to tell people, you know, you can have from really, really mild to a little bit more aggressive to overt confusion to being unconscious. And, you know, obviously, anytime you get into that overt confusion, that's the problem. So these milder symptoms, we can manage them. That's what we want to try to do. Lactulose is the preferred treatment by insurance companies. It's not my preferred treatment because the patients hate the medication. Rifaximin is my preferred medication. It works great. People tolerate it well. It's incredibly expensive. So if they're not on Medicaid or have private insurance, I have a hard time getting them covered. There's no need to restrict dietary protein for these people. That's old information. We used to say that 20, 30 years ago to not allow them to have protein. These people need protein. They become protein malnourished, and that just exacerbates the problem. And in an outpatient setting, there's no need to draw ammonia levels. You treat encephalopathy by symptoms, not by numbers on the scale. Some of these folks will run consistently high numbers on ammonia levels, and they're fine. That's their baseline. So it's not a true result. Okay, next page. Maricel hemorrhage. So this one, obviously, I don't do anything with them. I don't do the scopes. I don't, you know, get in there, and I don't do the banding. But I do try to explain this to them a lot of the time. We really try to prevent this from occurring instead of trying to chase it afterwards, because if we can prevent it, it's much more manageable. So I try to get everybody in for at least a screening endoscopy, just so that you guys know some of the local or more rural providers that do these scopes, they don't necessarily do banding. So that might be something to think about. You know, if they're a decompensated cirrhotic and you're worried about varices, you might want to try to get them in up here, because we all of our guys do banding, and there are 12 of us now that are doing them, but they're going to need banding in order to prevent problems. We also treat with sclerotherapy, coil embolizations, BRTOs, those kind of things. We treat with TIPS. TIPS is kind of hard to come by sometimes because their milk score is usually pretty bad. Sorry. Hello, hey there. Sorry, I got a phone call in the middle of that. So TIPS is hard to come by because our milk score is usually higher than 15, which makes everybody, you know, up in arms about it. Or if they have a little bit of confusion, nobody wants to do a TIPS. So we're really kind of, you know, relegated back to that non-selective beta blocker regimen, and then routine screening exams. Okay. Ascites, edema, hepatic hydrothorax, paracentesis. These are, you know, all in my wheelhouse, I suppose. I do paracentesis here in the clinic, in case nobody knows that. We have about 3 occurring every week so far. You know, I do require a little bit of basic lab work to have them get it done if they're not my patient, but I have no problem with people referring up here to get them into my clinic for paracentesis if they can't get into IR to do it. So just as an extra option for the patients. You know, what I worry about with these folks with the fluid overload, they usually have a pretty high tolerance. They'll take in, you know, sometimes 5, 9, 13 liters of fluid into their belly, and they're tolerating it okay. As long as they can breathe, it's fine. Please don't recommend Pleurix catheters to any person unless they're on hospice. Pleurix catheters have a 90% increased risk for sepsis and death, excuse me, for anybody with cirrhosis. Also for thoracentesis, we don't want to do pigtails hanging out of their lung to try to manage that fluid. We really need to try to figure out how to manage the fluid without doing that, even if we have to do serial thoracentesis. They just don't tolerate those things very well, and the liver gets really sick. Okay. And the last, of course, hepatocellular carcinoma. Depending on where the lesion is, they'll do radioembolization, which is a tear. They'll do a chemoembolization, which is TACE. Usually people that can't tolerate chemoembolization, they get kind of stuck at radioembolization and they can't go forward. So in order to get chemoembolization, they have to have, a bilirubin within a certain range. They have to have creatinine in a certain range. The alk phos has to be within a certain range. So chemoembolization is sometimes challenging to get to. We only use immunotherapy if we have multifocal liver cancer or if there is METS. And immunotherapy can be a challenge because typically these patients don't do very well with it and they don't live very long with it. Sometimes up to about 12 weeks is what we see. And it's always sort of a challenging dance to keep them stable enough to take the medication. Partial hepatectomy, that can do that if the lesion's in the right liver lobe, which is going to be more to your right side rib cage. Most of the time we don't see it over there so much. Those are more adenomas and other things that we see. So we don't do a whole lot of partial hepatectomies. And then, of course, transplant. Okay. This is just a list of common things we'll send you back from compensated to decompensated and back and forth. Certain medications can really, really cause people to decompensate. Antibiotics are notorious. They're kind of a necessary evil, obviously, but they are notorious for causing problems for liver disease. They will often make people become jaundiced. They just don't tolerate them well. Alcohol, obviously. Even falls, you have somebody who has stable fluid overload, they're on their medication, they're doing really well, and they fall on the ice. Well, now their belly is swollen, they have fluid in their lung, they can't breathe, and nobody can figure out why all of a sudden they're having this. Well, it just is that trauma to the body that the liver just can't filter it out anymore, and it just becomes an issue for them. Some of the more minor things like gynecomastia, this is a problem for some people because once they figure out that the medications are causing it, then they quit taking the medications and then they decompensate again. Extreme cachexia becomes an issue. It becomes a limiting factor for transplant. So all of these things can really throw patients from, stable to decompensated in really a short course of time. Okay. I just thought this was an interesting slide about cachexia. Like I said, we used to say restrict protein in these patients that have severe cirrhosis because they can't metabolize it. Well, the problem is they don't have enough protein. So if they're not getting it from food, they're taking it from their body and they become malnourished. So if you read these numbers and if you believe these numbers, advanced liver disease, they have a high percentage, but nearly 100% of people waiting for a liver transplant have severe malnutrition and is protein malnourishment. So I'm constantly pushing, protein milkshakes and high protein diets, etc. Okay. This is just a little bit of transplant exclusion criteria. Transplant could be a whole different topic altogether. But these are some of the things that I know that locally some people have been referred for transplant and transplant sort of kicks them back and says, nope, can't do it, or you're too early or whatever. The BMI is a real sticking point for most transplant centers. They really want it to be under 38. A lot of them are considering a BMI of 40, but not always. If they have ongoing uncontrolled infections, that's going to kick them out as well. If they have, the comorbidities like extensive cardiac disease or pulmonary hypertension, those kind of things will kick them back. I've had a couple of transplant centers push back on alcohol and drug rehab programs, even in people that have alcoholic cirrhosis that have been sober for 3 years. They can test for that. They can tell that they're sober, but they will make sure that they have to do these rehab programs or they won't allow them to even be considered. Depending upon the number and the amount, or the size rather, of liver cancers, that'll kick them off. Severe psych disorders like schizophrenia, that kicks them out as well. And then the MELD score. So, the working idea for a MELD score, if you look at the data online, everything says, over 15. Really, it's probably over 18 at most centers, unless they have a living donor, then it can be a lower MELD score. Okay. These are just a couple of cute little sayings that I thought were entertaining, to lighten the load a little bit, because, cirrhosis is pretty detrimental for most folks. People are terrified when they get to my office, and then they're really annoyed with me after I talk about all the problems that they can have. So I try to lighten it up a little bit. And these are just some sayings for you for future use.
Thank you so much, Jane. And I really like the drink water, surprise your liver quote. I'm always dehydrated, and I usually have a glass of water next to me during sessions, and I don't today. So that one especially resonated with me. But thank you so much. Wonderful didactic as always. Did anyone have any questions, comments, or thoughts that they wanted to share with the group? Feel free to unmute or chat in.
And just want to say that your didactics are always really helpful to me.
Oh, thanks.
Anyone else with other thoughts or comments?
Question, and this may have been addressed in previous echoes that I didn't make. But my question is, when these people bounce back and forth between decompensated and compensated cirrhosis, how does that affect our medication choice as far as treating Hep C?
It's a really good question, because decompensated cirrhotics really shouldn't be treated until they're well compensated. So until they're really under control and really stable, it makes it a challenge to treat these people. If you have a Child-Pugh score that's low, you have a MELD score that's low, any of the meds, they're all about the same, really. So any of them are fine. The risk is, though, that they can decompensate at any time.
Right.
So if they're already decompensated or having problems balancing things out, I try to make them be as stable as I can get them before I treat them.
Okay. So in the case where someone might decompensate mid-treatment, what would we do?
So if they decompensate in the middle of treatment, I take them off their meds. I stop
Okay.
the treatment, because the risk is that you can kick them into a point where their liver can't return. And the only option for them is death or transplant. And sometimes these
Okay.
people aren't transplant candidates.
Okay. Thank you. That was my question.
Yeah, thank you.
Thank you, Michelle, for the question. Any other thoughts or questions from the group? Alrighty, well, I will get into the announcements then, and then I will launch our monthly poll. It is voluntary, so please don't feel like you have to fill it out. It just helps us improve. So the only announcement I have is that our next session will be on October 28th, and we're going to have a group didactic by Dr. Moffitt, Dr. Reese, and Kelly Lemon, and they're going to present on HIV screen in pregnant women and children. So keep an eye out for that reminder.